and we will now move on to the Indian team, and we will call upon Dr. Ramurthy. He will be presenting phaco in nanophthalmos in small eyes.
Our good friends from Russia, a very warm welcome. We have informally met, but nice to be sharing the podium with you. Chairpersons, friends, this is the topic given to me. I'm actually going to give you just my experience of dealing with a patient with nanophthalmos. Basically, this was a 31-year-old male patient with one eye. He had a +9 with a 0.5 diopter of cylinder and 6/9 vision. Another eye, he had a +6/24 vision with a +14 diopters. Because obviously, it's an amblyopic eye. And this was the kind of glasses that he was presented with. And as you can see, he was very unhappy with the glasses that he had to wear and wanted some kind of a solution to this. So obviously, laser vision correction is not to be considered. And ICL is one choice, though these lenses don't come in that extreme powers. But then the fact was the AC depth was just 2.53 millimeters and 2.38 millimeters. So obviously that choice was also ruled out. Then we did consider the clear lens extraction. Basically, I'm against the concept of clear lens extraction in high myopes. Our retinal colleagues will understand of all the problems that it would create in the retina, whether it be on the macula or peripheral retina, and the propensity for retinal detachment. But there are pre-presbyopic age group in the 50s, 55, etc., when we have sometimes did this. So this person was 31 years old, but this was the only solution. We had a significant discussion with him, and he was willing to take it. The average K was, the cornea was quite steep. This is the axial length of the eye, obviously an anophthalmic eye. And the different formulas showed different intraocular lens powers. And the Hoffer Q, which is sort of advocated for these kind of eyes, mind you, this was about 3 years back that this case was done, was the outlier. And Holiday 1 and SRK 2 showed powers which are more nearer to each other. And that was the time we had access to the Varion. And this showed that, and I was laying on the Holiday 2 in those days, and it showed a power of IOL power of 49, which was very close to what the Holiday 1 and the SRK-T showed, 39 in the right eye and 49 in the left eye. And we had, today, if I was in a similar situation, I would have used the Barrett Universal 2 formula. But then we had to go with this, and we had, of course, counseled the patient that residual power might be there. So we subjected the patient to the all different investigation and ensured that the endothelial cell count is quite adequate, made sure there was not too much of higher order aberrations. The angle alpha, the angle kappa was not too high. The OCTV was quite pristine. So except for the extremely high power and extremely small eye, there's no other problem. So we had told the patient that the second eye, which required a 49 diopter lens, might require a second surgery, a second intraocular lens. We all know the challenges of operating on a patient with extremely small eye. Basically, mannitol was given preoperatively, significant acupressure was applied, and then I did it under topical, though sometimes peribulba might be advocated in such cases, especially if there's no risk of perforating these extremely small eyes. But as you can see, it's essentially phaco aspiration that's being done. But we are very careful to ensure that we got a good rhexis overlap. This was the first eye of the patient. A good polishing of the capsule is also done. And then single piece intraocular lens was implanted in the back. This was the eye which needed a 39 + 40 diopter lens. And subsequent, as you can see here, I'm slightly enlarging the incision from its 2.2 millimeters because these lenses are fairly big, and sometimes it's difficult to force them through conventional 2.2 millimeter incision. That was end of surgery with a good rhexis overlap onto the intraocular lens. And then when it came to, the patient had a satisfactory outcome. A week later, we took up the second eye. And this was the eye which required a 49 diopter intraocular lens. And basically, surgery proceeded as normal. And I implanted a +40 diopter. Nowadays, there are Indian manufacturers who are coming up with lenses beyond these powers and a custom-made platform. But this was the final outcome. plus 0.7566 vision in the right eye, and a plus 6 diopters 636. And that's when we consider a sulcoflex lens in the second eye. The simple formula is that for each diopter of hyperopia, you need 1.5 diopters, and we waited for a month. I think it was quite unnecessary. Maybe we could have done this surgery earlier also. The sulcoflex lens is about 13.5 to 14 millimeters in its overall diameter, and it again goes through a 3 millimeter or a 3.2 millimeter opening, and sometimes it's a good idea to use some of the larger cartridges to implant these lenses, and the company itself surreptitiously recommends that. And you can see it's almost a 6.5 millimeter optic. These serrations on the slightly larger haptics ensures that these lenses remain stable in the larger space that is available in the sulcus. Basically, the primary lens is a hydrophilic acrylic lens. The dictum is that the material of the primary lens and the secondary lens should be somewhat different. What went in as a primary lens was a hydrophobic acrylic, while this is a hydrophilic acrylic. And the orientation of the haptics of the primary and the secondary lens should be at 90 degrees to each other. So essentially 2 lenses go into this eye, and the final outcome was points. You can see that very satisfactory outcome. Of course, the left eye was amblyopic, so that's the reason it's 624, which was the refractive error, which was the best corrected visual acuity that the patient had to start with. So essentially, this is the presbyopic glasses that he's wearing now. A very satisfied patient. Of course, it's not a large series that I'm presenting, and basically this concept of using these sulcoflex lenses for correcting extremes of hyperopia might be a good option in our quest for good refractive surgery. Thank you so much.
Thank you, Ram. You're 51 seconds ahead, so let me ask you a question. So these are cases where we all fear, choroidal effusions. And I'm increasingly beginning to think that these are cases that I think we'll do well if we have an anterior chamber maintainer in the eye. Sounds somewhat simplistic, but when you come out with your phaco probe, or during IA you go in and come out, those are the times that these patients really get these effusions. The highest risk is at that time. And I think having a chamber maintainer is a very simple thing to do. Obviously, you don't have a large series, but it's a routine practice now in very nanophthalmic eyes to do.
Yeah, I think there are various suggestions that are made. There are quite a few even suggest sclerostomies to be made. In the sense that that's not depending upon the thickness of the sclera and the choroid. There's also been sclerotomies have been made, and they do it a week earlier, and they said that the chance of choroidal effusion is significantly reduced by that.
Yeah.
Yes, I mean, the challenges are always there, so it's not to be taken lightly just because it's a clear lens, and you could face problems.
Yeah. Well managed.
Yes, actually, as far as the intraocular lenses that are available for the conventional lenses that we use, plus 40 single piece aspheric is the highest power that we get. But there's a few Indian companies which are actually making it to order. But again, there is a challenge of getting the power calculation exactly right. So even you might get a 50 diopter, for example, what I got in that patient was something like 56 diopters. And we are expecting actually a residual of plus 9. But what we had was only plus 6. So splitting it up and doing in 2 segments gives you an opportunity to titrate the power more accurately, because the calculation for the second lens is fairly easy. One concern is in these small eyes where there is enough space, but then the normal anterior posterior thickness of the normal lens is almost 4 to 4.5 millimeters. These lenses are just about 1.5 millimeters in thickness. So there is enough space for 2 lenses even once you take out the natural lens.
Thanks, Ram. Thank you.
Thank you.
So our